Postoperative endophthalmitis following cataract surgery is one of the most dreaded complications among the ophthalmologists, especially in organizations like Arvind Eye Care System, which deals with vast number of surgeries every single day. Keeping all the factors in check to ward off this devastating complication becomes absolutely necessary. Apart from the basic checklist of operating room hygiene, sterilization of instruments, adequate operating skills of a surgeon, the need for an effective endophthalmitis prophylaxis is imperative in today's time. Historically, most options for antibiotic prophylaxis against bacterial endophthalmitis have been topical and subconjunctival. The use of perioperative povidone iodine and meticulous sterile preparation of the surgical site plays a significant role in limiting the incidence of endophthalmitis. The pioneer study of ESCRS in 2007 had the most scientific weight, in which intracameral cefuroxime revealed significant benefits. In 2013, the ESCRS published endophthalmitis prophylaxis guidelines that supported the use of a commercially approved cefuroxime formulation. However, due to its commercial unavailability, in 2014, ASCRS survey found that vancomycin and moxifloxacin were also commonly used as an intracameral antibiotic.
After povidone iodine, intraocular antibiotic prophylaxis is probably the next most effective way to prevent surgical infection. In the recent ASCRS survey, 2/3 of members are now using intraocular antibiotic prophylaxis, and of them 75% are choosing moxifloxacin. Some of that has to do with the risk of HORV from vancomycin, but also moxifloxacin is safe and has broad spectrum coverage.
Arvind Eye Hospital analyzed data of over 600,000 cataract surgeries and found that routine intracameral moxifloxacin prophylaxis reduced the overall endophthalmitis rate. Arvind indigenously prepares preservative-free moxifloxacin hydrochloride in packaged sterile glass vials. Each sterile 1 ml vial provides sufficient drug for 6 different patients. This dose of moxifloxacin is based on calculations targeting an anterior chamber concentration of moxifloxacin that would exceed the minimum inhibitory concentration for the susceptible bacteria. Use of intracameral cefuroxime and intracameral vancomycin have their own pitfalls, either due to dilution errors or high doses. Moxifloxacin, being a 4th-generation fluoroquinolone, has a broad spectrum coverage that includes both gram-positive and gram-negative bacteria and also many anaerobes. Thus, moxifloxacin was preferred against all the other available antibiotics, both because of its commercial availability in India and because of the evidence supporting its safety when injected as an intracameral preparation.
The Arvind data tells us that not only is it effective as a routine measure, but it's especially important in 2 higher risk groups. One was the manual small incision group, and this says that even if you don't routinely use it, then if you're doing charitable outreach, a large incision surgery, it probably makes a lot of sense. The other group is posterior capsule rupture, which had a 7-fold increase in endophthalmitis rate in the Arvind data, and that is the other group that you definitely want to use the antibiotic if you don't routinely do so already.
Arvind Eye Care System, being a network of 14 regional eye hospitals in southern India, has a surgical performance of more than 300,000 cataract surgeries annually. Being financially self-sustainable, cost containment becomes paramount to the mission of providing high-quality charity care to the indigent. The intracameral moxifloxacin study, done in 2 million eyes, showed that the rate of postoperative endophthalmitis without intracameral moxifloxacin was around 0.08%, whereas it was just 0.02% with the use of intracameral moxifloxacin. With this huge reduction in the occurrence of postoperative endophthalmitis, there is also a reduction in the extra cost and resources which gets borne both by the provider and the patient. Come to think of it, the extra expense of intravitreal injections, Vitreo-Retinal surgeries, multiple investigations, frequent hospital visits, and the loss of daily job or wages would be much more than the total cost borne by the hospital in their routine intracameral moxifloxacin prophylaxis, and thus offsets the total cost involved in managing post-operative endophthalmitis cases.
We started using intracameral moxifloxacin in August 2014 at the Madurai Arvindai Hospital. Within the first 6 months, we saw a significant reduction in postoperative endophthalmitis, and this prompted us to use intracameral antibiotic prophylaxis at all the Arvindai hospitals. While comparing this to the previous period, we see a significant reduction in endophthalmitis by about 3 to 4 times. None of the patients who received the intracameral antibiotic encountered either TAS or corneal decompensation, which was related to the drug. The total cost of the intracameral moxifloxacin was actually offset by the savings realized to a reduction in the postoperative endophthalmitis.
After all, cost is more important than quality, but quality is the best way to reduce cost.